We have Dr. Atul Mulay, the senior nephrologist from Deenanath Mangeshkar Hospital.
Okay. Thank you, Dr. Chakurkar, Dr. Lubu, and all KEM team for having me here. I'm going to talk about preventing infections in dialysis unit. So before I start, couple of questions. So how many of you are doing nephrology training right now? Like the form free DNV or free DM training. And how many of you are first year and how many are second year? Okay. So I presume that most of you are probably spending much more time in dialysis unit than me, right? I hardly spend any time in dialysis unit. So you are probably more used to and more adapt to, you have seen lot many practical problems in dialysis, and hopefully you'll be able to relate to some of the issues that I'm going to discuss. So the first thing is why it is important, why the infections are important. And obviously mortality, right? Our dialysis related infections kill patients. So if you see this USRD data, even in the US, which is an advanced country, if the causes of death in dialysis patients, after excluding cardiac and withdrawal from dialysis in elderly people, the third most common cause of death is infections. Chinese data, this is a large Beijing data, more than 25,000 patients on hemodialysis. What are the causes of death? Again, cerebrovascular, cardiac, and sudden death, nearly 45 to 50%. But the next most common is infection. And what is Indian data? So this was a study published recently. It was a case control study comparing deaths, and what it showed, what was the significant predictors of death was use of catheters. And presumably the use of catheters was associated with death because there was many more infections. So I am going to, okay, so the mortality is obviously the important thing, but equally important is morbidity and cost. You can imagine patients coming into getting admitted recurrently for infections, and it increases their morbidity, overall survival, and cost of dialysis. And the worst thing that I fear is the bad publicity. As you go out and start practicing, you will realize how difficult it is to convince a patient to start dialysis. Why? Why our patients are so much afraid of dialysis? Cost is definitely an issue, convenience, logistics, all of those are there. But one of the major reasons why patients are not willing for dialysis is because they feel that dialysis makes patients more sick. And why that happens? Because there are infections. So one of the people fear dialysis is infections, and it just gives a bad publicity to dialysis unit, but in general dialysis as a treatment modality. So that's why it is very, very important to ensure that we minimize or eliminate as many as possible. I'm going to quickly look at viral, bacterial, and then a little bit about epidemic and pandemic situations. Okay. So before we start, we will have to go to a good store, maybe multiple stores, and buy lots of different hats and fill our wardrobe with lots of hats, because you're going to need to wear different hats if you really want to reduce the number of infections in dialysis unit. Alright, so let us first wear the doctor's hat, the clinician's hat that we always wear every day, right? I'm going to go through the viral infections first, because I think right now I'm not so much worried about that. Last 30 years, we have spent endless sleepless nights and nightmares because of all these Hep C and HIV. But I am pretty sure that in the next 30 years, not going to have this as a major issue. Okay, why? I'm going to tell you that. So hepatitis B, obviously a major worry. It is highly contagious. The spreads, bloodborne, fomites, everything. So how do you prevent dialysis associated hepatitis B transmission? Of course, screen every patient. At the time of admission to dialysis unit, including transfers, we did discuss a little bit about that, and I am going to have my take on that shortly. Screening every 3 to 6 months is mandatory. Every unit has that. Vaccination is important. And why? That's exactly the reason why hepatitis B is going to be is going to cease as a problem in the next 10 to 15 years, because since around 2000 or so, we got a national program of immunization. So anybody who is about 25 years or older than that or younger than that today is likely to be vaccinated. All right. So we don't have to worry so much 10 or 20 years down the road. So in your lifetime, you will probably not have much issue of Hep B. Right now, out of 30 dialysis machine that we have only one dialysis machine for Hep B, because it's so less now. So maybe we are looking at all this HbA1c monitoring all the time, and even starting HbA1c screening at CKD stage 2, stage 3. Maybe we should now start focusing on anti-HbS titer, because most of the patients are likely to be vaccinated in near future. So maybe we should look at HbA1c titers more frequently, even in the pre-dialysis and of course in dialysis. In hemodialysis unit, typically annually we have to monitor, and whenever the titers drop less than 10, you need to give them a booster dose. If you have a positive patient, how do you dialyze? So if you look at the CDC recommendation and even the Indian Society of Nephrology recommendation, hemodialysis recommendation, which is also adopted by Minister of Health, by the way, that is available free on the web. So you can go through that guideline. But all the guidelines will recommend that all positive, Hep B positive patients need to have dedicated machine, preferably a dedicated space, so separate room, isolation room, and I would say on top of that separate staff, no reuse, and of course all of them need to be treated with antivirals. Okay. So we need to go a little bit beyond guidelines, because guidelines are often considering quite ideal situations, and a lot of the times Western standards. We need to see what is happening on the ground, and many times there are slips between cup and lip. So what we advocate is sometimes not practiced very properly. So we need to take all those factors into account. Coming to hepatitis C, again, every patient needs to be screened. Now we just had some discussion about that, right? And I also agree with that, that we probably have, these are again some guidelines. We probably have to move from anti-HCV to scRNA. I think this time has come that anti-HCV, even we are all of us using third generation ELISA, etc. But the problem is that there is window periods, and sometimes you don't pick up, the kits are not good, and therefore, and the cost is come down. HCV RNA testing kits or NAT testing kits, the cost is not huge. So I think the time has come that we move towards HCV RNA testing as a routine screening for hepatitis C, especially for transfers. If I have Hep C negative patient in my unit, I'm just doing a 3-monthly test, maybe a third generation ELISA is okay. But anytime there's a transfer happening, then maybe it's good idea to have a NAT test or a RNA test. Now this is monthly ALTS, AST, this has been there in guidelines, and that, and 30 years back we had a dissertation about that. But today I would say that it's not going to be of much help. You know that ALT-AST levels are very low in hemodialysis, and maybe even with infection, the AST-ALT level will be in the normal range. So we don't need to, I mean, we shouldn't be looking at the absolute number. We should actually looking at that. That's very difficult to do, and as such, it is not very reliable. So maybe, hopefully, in the next 5 years, NAT test for everyone. Now, for dialyzing hepatitis C positive patient, is isolation necessary? And that's a little bit of controversial, because the guidelines, we look at guidelines, especially the Western guidelines like CDC guidelines, they say that you don't need a dedicated machine, you don't need a dedicated staff, you don't need a dedicated space. You just follow the standard universal precautions and you're fine. Because hepatitis C transmission is a little bit uncertain, probably fomites and touch, etc., bloodborne. But it's not very, very infectious virus as compared to Hep B. But in our country, again, the things are different. And if you look at Indian Society of Nephrology guidelines, isolation is recommended. And I would also strongly recommend isolation. So dedicated machine, if preferable, dedicated space. And I would also go one step further, no reuse even for Hep C as far as possible. If you separate the areas totally, then only it is possible to actually prevent Hep C transmission with some certainty. Because if you got one single hall and at the corner you got 2 HCV positive machines and all other are negative machines, then the staff is all mingling everywhere, and then it is very difficult to prevent transmission, which are best practices that you practice. Now, we had, like in Deenanath 25 years back, when we started, it was just single hall, and there are 2 parts of that. We had lots of HCV at that time. About 12 or 13 years back, we moved to a new building, which is a super special building, and we have a large 30 bed dialysis unit. So now, at that time, initially only, at the time of design only, we designed it such that there will be a separate room for HCV. Okay. The separate room for HCV, the staff stays inside, the reprocessing happens there only, the separate, so those machines obviously are dedicated. And since then, we have had hardly any HCV transmission. Going forward in future, for you people who are going to be practicing for next 20 or 30 years, I think even HCV is likely to be not a big problem because of the availability of antivirals. Okay. So even that one room of HCV is now getting empty because we are treating everybody with antivirals, making them negative and confirming that they have sustained viral response, and then treating them as negative. And this is going to happen soon. So yes, you will probably have 5 to 10 years of this, but beyond that, hopefully HCV is not going to be a major headache at least. Now HIV, a big headache. If you look at any guideline, they will say the same thing, especially Western guidelines. No need to isolate, no need to have a dedicated staff, dedicated machine. Just follow standard precautions. But for practical purposes and Indian Society guidelines also, they have recommended isolation. And it is a difficult thing to dialyze HIV positive patient in a common hall for a lot of different reasons. Taboo is one of the things, and ultimately we have to look at however scientifically you can explain people that this is absolutely safe, don't worry, transmission is not going to happen, right? It is difficult to convince all the other patients. And you know that our staff will have break in their protocols. And then the whole headache is going to be borne by us. So preferably again, same as Hep B, Hep C, separate room, separate machine, separate staff, single use. No mixing of staff, machines and any equipment between the positive side and negative side. That is the only way of doing it. That's my opinion again. All right, and regarding this, just the other side of this is we have to make sure that your staff is vaccinated for Hep B and they take adequate precautions and protocols are in place to prevent needle-stick injuries and address the needle-stick injuries as if they occur, because you are equally responsible for health of your staff. All right, now we are going to move to this more important, the most troublesome factors that actually happens unfortunately reasonably frequently in our unit. How to prevent bacterial infection? That is the worst part. Those are the things which are going to kill patient immediately. Hep B, Hep C will take long time, most often. Very rarely an acute Hep B will happen and patient will die of ALF. That is very uncommon. Most of them, they'll just develop Hep B, Hep C. You can treat them, they'll live for a few years or many years maybe. But bacterial infections are pretty bad. Patient can die in 2 days. Okay, so absolutely important to focus on them. Now again, there are protocols. I'm just going to be a little bit practical. So how do we have protocol at the time of cannulation of an AV fistula? So first is hand hygiene. I'm just going to run through a few things. Washing access site with soap and water before, okay? And you have to instruct the patient also that before coming to the unit, they have to wash the access site with just soap and water. It doesn't have to be antiseptic. If you have antiseptic soap, good. Otherwise, just soap and water is also fine. Then you need to prepare the area properly. Use of gloves is mandatory. and preferably sterile, doesn't matter even if they are ETO. Sterile drapes, again use on and off kits. Nowadays these on and off kits are starting kits are pretty cheap. Usually each kit has some sterile gauze, even sterile gloves, and places to keep your antiseptic solutions. And then you can just use one kit for every patient at the time of start and at the time of end. It doesn't cost a whole lot. We are able to get in 25 to 30 rupees. It's not a big deal. So what are we going to use for antiseptic? This is the most effective one. Okay, about 2% chlorhexidine with alcohol. If that is not available, at least 70% alcohol. Okay. Don't use betadine here. It is not recommended. It's not as effective. All right. Now you need to apply it properly, scrub in centrifugal manner, at least for a minute or two, and allow it to dry. Okay. Allow for the action of the antiseptic to happen, and then only start cannulation. And keep the needles, the hubs closed at all the time. This is true for the catheters also, but also true for AV visceral needles. Okay, just don't cannulate and go away and leave it, because then it will keep on hanging and touching everything else, and then it can contaminate. So anytime there is a hub, you must either cap it or attach a syringe to it. And once you are once it is in the sterile area, then make sure that it doesn't touch any other unsterile part. Either the body part or any equipment. What about catheter infections? Again, AV visceral infections are less common. That happens which very, very unhygienic situations. So it's less common. More important for us to prevent is all these catheter related infections. And for better or worse, we just heard about elderly people and all. But what is happening now, and this is going to happen with you even more, that the causes of ESRD are changing. Most ESRD patients are now diabetic hypertensive, and most of them are elderly nowadays. Okay. Younger patients will probably have ESRD, but they'll get transplanted and they'll move away. So we will be stuck with all these old people, 60, 70, 80-year-old people who are either not fit for transplant or don't want transplant, and they will be on dialysis. So those are the people who will be on dialysis, and many of them unfortunately don't have a good possibility of getting an AV fistula done. So we all know FF, right? FF is fistula first, right? So FF is the best policy, but unfortunately it is not possible. So we are stuck with the catheters, pump cas. In our unit, we are almost 60-70% pump cas now, because that's all we can do. So we need to do well to prevent the infection associated with the pump cas. So first thing, look at the exit site. What you can do? Regular cleaning using antimicrobial solutions and dressing. Question is how frequently? How frequently you should do those dressing? How frequently you should open the dressing and change and clean it? So the guidelines usually say that it depends on the type of dressing. So if you are using an opaque dressing like a gauze pad and then micropore or something, or dynaplasm, micropore typically, that kind of dressing through which you can't see the exit site actually, then you probably have to open it every time. Every time the patient comes to dialysis center for dialysis, before starting dialysis, open it, check it, clean it, dress it, and then start dialysis. If you have got a dressing with a transparent dressing like tegadam, through which you can see the exit site, and the exit site is not covered by gauze, then you can observe the exit site and see if there is redness, any discharge, okay, any swelling. If that is not there, then once a week changing tegadam is enough. You don't need to do it every time. Okay, that's the guideline. Question is which antimicrobial? I'm going to show a list of my antimicrobials. And what about the compatibility? Compatibility issue, again you need to take into account, because chlorhexidine sometimes is not compatible with certain types of pump gas, typically polyurethane and some other. So you need to check that and make sure, because otherwise if you keep on using that, eventually the external part of the catheter becomes soft, it gets deformed, and then leads to more infections or even malfunction. So that factor you need to consider all the time. Okay, so that is the available options for antimicrobials. Now again, let us make a distinction between antibiotic and antimicrobial. So mupirocin is antibacterial. Okay, so mupirocin, as you know, is a gram-positive effective antimicrobial, right? There are concerns of that, including the routine intranasal screening. Now, there are some centers that follow that, and probably many more centers used to follow it in the past. Screen all the patients for SAF carrier status and then treat them and decontaminate them, okay, with intranasal mupirocin or sometimes systemic treatment. The problem with that, okay, that was based on the data which were like 30 years back, 25, 30 years back, that 70% CRBSIs in dialysis patients were gram-positive. Okay, so you just take care of gram-positive stuff and you're fine. But after doing that, people have realized that, okay, gram-positive infections go down a little bit, but you are promoting maybe gram-negative infections. So many centers don't do that. We don't follow, we don't actually screen this part. So this part we don't do. There is a real concern about having gram-negative increase. And in general, if you look at any antimicrobial spectrum in any unit today, secondary to CRBSI is associated with PERM-CAS, majority are gram-negative. Gram-positive are much less common because overall improvement in the care in the last 20 years or so. So mupirocin being an antibiotic, specific gram-positive, I would not happy with using it. We need to use something which is an antimicrobial, which is a broad spectrum, doesn't promote any resistance. So povidone or this chlorhexidine gauzes, they are better for applying on the exit site. Okay, and they are shown to reduce in trials. They are shown to reduce the exit site and catheter infections. Now, once you have done that, then you come to the step of connecting and disconnecting later on, right? So the step of connecting is most important because most infections happen at that time. Okay, all the breakages of protocols happen there, and that is when you are. Whenever I am saying you means your staff, right? So when you are going to introduce infection or bacteria in bloodstream at that time. So the utmost care has to be taken at that time. And if you look at again protocols, let us say from CDC protocol, you will see this highlighted, scrub the hub. Okay, what is scrub the hub? So the hub has to be, now you need to, I'm going to show you that, but don't read it, you just read it and know it how it is done and teach your staff how it is done. Okay. So basically the basic principle is what? Whenever there is all the, both the ports are capped, right? So one option is once you have cleaned the exit site and draped it properly, then you start dealing with the change the gloves, okay, change the gloves and start dealing with the connection process. Then one option is to first disinfect the caps and the external part of catheter with again chlorhexidine and spirit. Okay, the chlorhexidine solution. That is optional, but once you do that, once you remove the caps, you need to remove caps one by one, not both at the time or both at the same time. One cap at a time. Remove only one cap. Okay. Clean the hub. And how you clean the hub? That is the protocol. Okay. That is the protocol of cleaning the hub. So it needs to be scrubbed properly for at least a minute or two, or not just hub, but the sides, the threads, and the portion of the catheter which is adjacent to it. Okay. That needs to be thoroughly clean and allowed to dry. And once you have done that, then that's a sterile area. Then again, prevent contamination or contact of that part with anything which is likely to be contaminated. Again, the same thing as if fistula needle, don't allow it to just remain open. Either you attach a syringe there or quickly attach the tubing. Don't leave it open for too long. Then change the swab, go to the next port. The venous or arterial whichever. Okay, so two different swabs to be used, not the same swab from one to other, and proper scrubbing, ensuring all the visible matter like previous blood clots and some fibrinosis, etc., dust particles to be visibly clean from that area. So that is a scrub top that has to be followed, and that has been shown to again reduce infections in trials. So this is very, very important. Then, and the same process, similar process has to be followed at the time of disinfection. The question is again antimicrobial locks. That's a very burning question because a lot of people feel that antimicrobial lots could be used. It's very easy, isn't it? Why to worry about the infections? Just use a antibiotic and finish with it. So there are lots of pros and cons of it, right? So ideally, the antibiotic lots should be helpful, because if they are broad spectrum antimicrobials, then they will probably prevent gram-positive, gram-negative infections both. Okay, they should also inhibit the biofilm, because that sometimes can be a more problem. They should reduce the CRBS risk, but not only that, they should reduce mortality also. Okay, so morbidity as well as mortality. But the problem is what? You may promote resistance of resistant organisms, and when you use locks, there is always a risk that whether the catheter will malfunction, whether there will be clotting, and you will need to actually use more urokinase or more TPA or something like that. And the last part is, of course, systemic toxicity. So that also I am going to tell a little bit. So those are the risks. But in general, if you look at the systematic review and meta-analysis, this is a recent one, about 30% reduction in the risk of CRBS is achieved by using different types of antimicrobial locks. So should we use it in every patient? So let's see. So these are the ones that are available. So let us start from maybe this side. Okay, antibiotics. Gentamicin, very popular, especially small units. We had some discussion about small units, and they use gentamicin very frequently. And I have seen patients going deaf because of that. I have seen patients who are not able to walk because of that, because of the ataxia, who are not able to even stay steady at one place because of those severe vestibular ataxia that can cause. So it is very, very strongly discouraged. Don't use gentamicin yours unnecessary for every patient every time. Okay. Now, if we decide to use gentamicin, how should we use? The standard high dose is the 4 milligram per ml solution with heparin. You can make it. It's very cheap. Okay, and just fill the length of the catheter, the volume of the length of catheter, and leave it until the next time, aspirate and discard before you start dialysis, so that none of that goes into the patient. But again, you have to be very sure what your staff is following, because they sometimes just inject and gentamicin just goes inside. Now, newer thing is this load of gentamicin, which is just 0.32 milligram per ml with heparin or citrate. And honestly, I have not used that, but studies have shown that even this is effective. Okay, so maybe this can be used. Let us go to citrate. Again, a popular thing, and I sometimes like citrate because of two things. One is it is available, it is not very expensive, reasonable cost effectiveness. Okay. Now, citrate, what you need to remember is a 4% citrate is not effective in reducing infections. It may reduce the clotting part, but it does not reduce infections. If you want to reduce infections by using citrate logs, then you need to go to high dose, high concentration. 30% of 47% is available. So you can use that, and we use it sometimes. But again, toxicity. Okay, if certain part of the citrate goes in, then what is going to happen? It causes hypocalcemia. It can cause tingling, numbness, and things like that. So patients can become very uncomfortable. So you have to be very careful while using that. Toluidine, I don't think we have it available. So supposed to be the best now, and I'll just show you one slide. This is the only one which is actually approved by FDA in the US couple of years back. No other lock has been approved by FDA in the US. Okay. Altiplase, very attractive. The TPA very expensive, so practically impossible to use. And then lastly, ethanol. I would just go to ethanol lastly. That's an interesting thing because we have started using it now. So ethanol also, if you want to prevent, you need dose, and 30 to 40% or 70% ones you should use. 30% with heparin or 70%. The problem is that again the toxicity, compatibility, and the catheter dysfunction. So you can use it with heparin. 70% we are not using as a catheter lock. We are using 70% now. We have just recently started after some published data, including Indian data, which has shown that it is very good after an infection. So to sort of decontaminate the perm cath, it is useful. So there is a protocol, published protocol that we follow Just use 70% alcohol, fill the lumen for 4 hours, and then aspirate and discard. And do it for 5 days consecutively for in each lumen. And usually the recurrence rate for the infections is much lower after that. So that's what we have started following now. But as a routine log, definitely no. So this is, as I said, this is the only one which is actually approved by the US FDA as a catheter locking solution. Don't ask me the cost. If you find out the cost in the Google, then you will probably stop going to dialysis unit at all. Okay. So as I said, other than this, nothing else is approved by FDA. And also CDC does not recommend it to be used as a routine. But CDC also says that for a certain amount of time you can use. Okay, so somebody who has had an infection, catheter infection, or having recurrent infection, then you can use it for a short amount of time. 2 weeks, 4 weeks, then stop. Okay, except maybe citrate, the high concentration citrate for a prolonged period toxicity, because it serves both purposes as an anticoagulation lock as well as the anti-infection prevention lock. Alright, now this is the next thing that you may be able to use in hub devices. There are 2 in the US now. One is this Tego with QMO caps. The QMO caps is nothing but the alcohol, isopropyl alcohol caps. So, and the other one is this clear guard. I'm just show you quickly. So this is the Tego. This yellow thing is a Tego device that needs to be attached to the catheter. It is a needleless entry port through which they can achieve very high flows. So there are dedicated Tego devices for the hemodialysis machines as well, and these are the QMO caps. So you just they are basically filled with alcohol. So you just attach them at the end, and that will sort of decontaminate the tip hubs. And this is the clear guard device. It is a cap with this short stick, and the inside of the cap and the short stick are impregnated with chlorhexidine. Okay. So at the end, once you're done, you flush the catheters, you just cap them with this. Okay. The cost of this is not that bad. So I presume, and this is the one which is approved, so I expect that this will probably come in market in the next 3 to 5 years and maybe usable in some patients. This is the data, published data. I have taken this from the ClearGuard site, so, but it is a published data. So ClearGuard compared to the standard heparin locks significantly reduced CRBSIs, and ClearGuard also significantly reduced CRBSI even if compared with the Tego. Okay. So that's probably why the FDA has given approval for this in 2023, so about just 2 years back. Cost I think will come down. Hopefully we'll see this in the next 2-3 years, and that will help a lot. Alright, so now you have to take out your clinician's cap and put on a manager's cap, because you have to not take a step back and stop seeing the individual patient, see a group of patients, a huge number of dialysis patients, the entire patient that you are managing. Okay. And there's a lot of managers' migraines that you have to go through. So, okay, what about dialysate? Can it be the source of infection? Can it be the source of contamination? Of course it can. All the dialysate, everybody has, all of us experience this. We make the cans and then maybe use it for 2 days, 3 days. How they are kept, where they are kept, who is handling that, where they are capped or not. So all of that one has to take care of it, and therefore I personally feel that at least dry bicarbonate gets rid of at least part of it, and I strongly feel that dry bicarbonate, which a lot of machines have that option, does increase the cost by about 50 to 70 rupees per dialysis, but I think it is worth it. But we have to look at the dialysate cans. If you are using when the both part A, part B cans, then we have to look at asepsis of those cans. Or machine disinfection, so typically heat disinfection after each use and chemical disinfection at the end of the day. Surface disinfection after every use of machine, and also beds and all other surfaces. What about dialyzer use? Now, with apologies to my teachers and all my colleagues, there is no real benefit of dialyzer use except to save a few bucks. And I think that time has come that we move away from dialyzer use. Okay, we can get cheaper dialyzers. Cost of reuse that actually the unit bears, the hospital bears, which is not passed on to the patient. If you calculate the cost of reuse, every reuse the hospital spends about 100 rupees, at least 100 rupees, if not more. And it is a big burden for manpower, so it's very labor intensive, and that is where a lot of the problems happen. So in the morning we talked about a lot of this, rigors and fever and chills, etc. And we talked about this, right? Just get rid of that. And today we are able to get dialysis at 350 rupees, 400 rupees, we are using a dialyzer of 800 or 1000 rupees and then using it 5 times. Why not use a 350 rupees dialyzer, which is equivalent, and just single use? Anyway, but definitely do not reuse tubings. Stop from today. Don't reuse tubings. 120 rupees. Absolutely no cost effectiveness in using that. Okay? Because the amount of manpower and water and chemical that you use to reprocess a tubing is just not worth it. Just pass that 120 rupees to the patient and they will be happy to take it. Water treatment system, we are going to have a detailed lecture, so I'm not going to talk, but this is important part because a lot of the endotoxin can come and chills and rigors. It's difficult to then differentiate from the infection, true bacterial infection. General hygiene, again, in general hygiene as such is very important, and again as a manager you need to look at that. What else you can do as a manager? You need to prepare checklists and protocols. So you need to prepare checklists of patient care. So whatever we just discussed in the morning, the AV fistula, cannulation, the exercise and the connection, disconnection, this and that, all of them protocols. Prepare SOPs, file them, keep them in your dialysis unit at very easily readable and accessible place so that the staff can see that very easily. Then machine maintenance, machine disinfection, water treatment system, maintenance, disinfection, housekeeping and cleaning. So all those protocols we need to make and then provide them to the relevant people. Surveillance is important. Surveillance regarding different things. So there are surveillance cultures from the surface. We actually stopped surface surveillance culture because our people said it's not worth it. So we have just recently stopped surveillance culture. Okay, but other surveillance that I'm going to show you surveillance. Incident reporting system. This is very important because we have a tendency to brush everything under carpet, not reporting. नहीं हो गया था ना उसको last time भी आया था ना chills. अरे last time आया तो last time बताना चाहिए था ना chills आया था. So that is the thing. You should encourage the reporting right at the time of events so that you can take action at appropriate time. And then monthly review meeting. We have started this few years back. It's very, very important. As a team leader, you should have in the monthly meeting, you should have your manager, your senior technicians or the nurses and the residents or the doctors who are present in the dialysis unit. So sit with them for an hour or two once a month and go through whatever happened in the last month. And those things that you need to just, you can decide for your own unit which things you want to monitor every month. So what we had decided for ourselves certain critical incidences that have to be reported, that have to be documented and be monitored every month. And then carrot and stick approach, you have to have some incentives and some punishments. As a manager, you need to do that. So an example of a checklist from abroad, but this is what we use in our unit as a checklist for before every connection. The left one is for the AV fistula connection, the right one is for the pump cath connection. We are all online systems, so all our dialysis flow sheets are also online. So, but before accessing the dialysis flow sheet, the technician or the nurse have to access this, fill this, and then only they can access the dialysis flow sheet. Otherwise, they are not able to fill the dialysis flow sheet. Okay, now let's wear the hat of educator and teacher. Now what we need to do? Because none of us are actually going to do the connections, right? So somebody else is going to do for us. So we need to train them. So induction program is very important. Many of our units, especially the big hospital units where there is a mix of nurses and technicians, it's a moving population, right? All of the people will work for a year or 2 years and they go. So by the time you train them, it's about time that they leave. So it is important that when they join, they should first have a good structured program. So that is what we call induction program. So we have an induction program, few lectures, and then some supervised training by a senior staff. Okay, that is done for 2 weeks at least. Okay, that is very important. Then you should have a credential, certification and a privilege system. Why? Because earlier as I said that everybody cannot be trusted with reprocessing if you are doing reprocessing. Then you need to have dedicated people doing dedicated tasks who are specially trained for that. Then you can monitor them and then hold them accountable. So if you are using reprocessing, only 4 persons will do reprocessing. No other will do it. Same with the water treatment system. Only these 3 or 4 people are allowed to handle water treatment system. They will look after their maintenance disinfection. These other 4 people, let's say, will look after machine maintenance. Okay, so machine disinfection, machine maintenance, all of that. So you divide your people, seniority, juniority, what is their background, what is their educational, and what is their smartness quotient, and depending on that, train them and then allocate specific duties, and they also then become responsible. They also feel that they have got getting some specialized work, so they are more incentivized. Regular training is also important, not just induction program. You may, if you have a large unit, you may have 1 or 2% dedicated as an educator among the staff, either the senior technician or a senior nurse, so that they are responsible to conduct all these training activities in the rest of the staff, and you just monitor. Patient education, neglected part, but I can assure you it is one of the most important, one of the most efficacious ways of preventing a lot of incidents in dialysis. So we had started using doing monthly patient meetings, open house sort of, and give them some educational program, and sometimes you can talk about infections with them also. Okay, now we are going to change our hat again and go to research and audits. So despite doing all that, things can go wrong, and you need to monitor whether the things are going right or wrong. So you need to have regular audits and have some kind of research as to what is happening. So you are doing surveillance, but you need to interpret that data. So you need to have a couple of people responsible to do that. Then you need to have investments in outbreaks and seroconversions, which is hopefully very uncommon nowadays, but you need to have a system for that. So for that you need to label your machines properly and do proper documentation. Which patient was documented on dialysis on which machines at what time. You need to be able to trace that all the time. So traceability is very important. Only then you are able to do audits. Then you can do audits of different things. You can do audits of protocols, you can do audits of events, and you can do audits of outcomes. So protocols means what? Whether the staff is following hand hygiene, whether the staff is following the scrub before the hub, okay, that kind of thing. What about events? So you can audit events like CRBSIs, exit site infections, or cold blues, or things like that. And what about outcomes? You can audit, like it was discussed in the morning. You have some target medical parameters. What is your hemoglobin level? What is your calcium level? What is your PTH level? So those kind of things are your outcomes. Those you can audit. So you have all these sets of parameters that need to be audited regularly. Now I'll just give you a couple of examples. This is our audit maybe a couple of years back. So what were the points? Dressing of dialysis catheters. So what we did was, just observe. We were tasked a couple of people, senior people, to observe the staff and just see, make a point. There is a chart. I will show the chart. Whether they have followed all the protocol, because you can just write the protocol, but how do you know whether they are following it? And the other part was specified major incidences, and among them CRBSI was one. So this was a simple chart. So the observer was just observing and checking whether at the time of this particular connection, did the staff follow all these steps or not? Just yes, no, simple. You can devise your own, not a problem, and then review that in the 6 minutes. Provide feedback, because that's very important. So this is data, again the monthly. This is what we mean by surveillance, isn't it? What is surveillance? Every month you just see how many infections have happened, how many exit site infections are there, how many CRBSIs are there. So you get a monthly data, you get a trend. So just chills And actually CRBSI means a positive culture. Okay, these are only chills, but these are positive cultures. And then some patients, our own patients, some patients have come from outside, some are existing infections. If you have got this for 6 months, 8 months, then you know that if there is a spike, okay, so you are getting about 5, 6, maybe 4, 5 infections every month. Suddenly 1 month you get 9. Then you start to sit up and review everything. What is the problem? Okay, so that that needs a lot of Sherlock Holmes like activity. Okay, but that one needs to go through and provide the feedback, because otherwise the staff doesn't know what is going on. Okay, we need to keep on providing feedback to the staff, what is right, what is wrong, what was the problem, why things are going wrong, and then get back to the correct things. Now what is this? It's a warrior's hat, right? So we have gone through pandemics and epidemics, hopefully not very often, but in your lifetime you are going to go through this. In the last 20 years we have gone through it twice at least, right? COVID and swine flu. Both were disasters. Our hospital was one of the largest private hospitals which was taking care of both swine flu as well as COVID. At one time we had 450 patients of COVID in our hospital, dedicated building. 2 dedicated buildings actually filled with COVID. So when faced with such a situation, how do you do? So first and important thing is get reliable information from reliable resources. Okay, and it can be different. This time it was a respiratory infection, but it could be something different, virus, mode of transmission may be different. So find out what is exactly the scientific information from reliable scientific resources from national and international. So WHO, CDC, our Minister of Health, or our own professional societies, they will also come out with the information. Then based on that you need to make new SOPs only for that period. Okay, so COVID protocols, okay, they may not be applicable today, but COVID protocols were very good. We had to just come up with COVID protocols. How do you isolate it? How do you screen the patient at the entry? So we have that protocol. Every patient coming to the dialysis center outside, just the first room, you check temperature. There was a person asking 4 questions about the symptoms, and if you find there is a potential infection, send them to a dedicated unit. Okay, so this is our isolation. Then we had separate unit for dialyzing. So things like that. So depending on the situation, you have to make new protocols and make sure that you are implementing that. Then you need to go through guidelines from all these regulatory bodies and government, because you cannot be on the wrong side of government and this type of situation. Make sure that you are following all the government and related regulatory guidelines properly. You need to update regularly and disseminate the information. So therefore the effective communication is very important. You need to have good communication with staff as well as patients and other departments. Okay, because dialysis is such a thing that you are going to do all over the hospital. So you need to have protocols for ICU, protocols of how to dialyze patient admitted in wards. Okay, and of course patient need to be informed regularly. And collaboration with other units and other relevant agencies is very helpful. You need to find out. Suppose I don't have facility. I have only 5 machines, and I cannot isolate a COVID positive patient, right? So what can I do? Okay, I know I have a friend who has got a big unit. He has a dedicated facility to dialyze COVID positive patient. I'll send it to him. So don't just send patient to fend for themselves. Take care of them. Find out, okay, if I'm not able to do it, I'll send you there. Okay, you do it there until the epidemic is over, then I'll take you back. All right? Okay, just last slide. Certain things that we have learned over so many years now, and I think Vada sir will agree with me this. It's very easy to set up a protocol, especially in our country, but very, very difficult to implement in perpetually. You need to be on top of it all the time. Make sure that the protocols are followed. Otherwise, making protocols alone is not going to be enough. We need to be agile and responsive to ever-changing world. Things keep changing. Hep B is changing, Hep C is changing, and the newer infection prevention strategies and devices are coming up. So we need to adapt all. Like start on-off kits were not there maybe 10-15 years back. Now we are using it. Quality versus cost, always a balancing act, and we cannot be very much dogmatic about quality, ignoring cost also, but at the same time we have to follow certain minimal standards excellence and access is always a problem. If I have very high standards, then I will not be able to deliver service to a lot of people, and then patient will be actually not served very well. Success is more than an individual brilliance. So, however good I am doesn't matter. That does not decide success of my hemodialysis team or my unit. What I need is soft skills, and I need to work with a team. And if I am able to do that, only then my unit is going to prosper. You remember, this is the most important thing in any walk of life. Individual brilliance has only one part. You need to combine it with soft skills and a good teamwork, good communication, and social skills. Only then you can translate that individual brilliance into something which is actually useful to the society. And aim to build up a fearless organization. This is the last one. So definitely read this. What is a fearless organization? People should be empowered to speak, to point out, to make suggestions, recommendations, and then you can have a system of going through all of them and then accepting the right things. All right, I think I'm going to end here, and if there are any questions, I'm ready to answer.
Thank you for the excellent talk, sir. I have one question, that HCV treatment is being done for a patient. He has completed his treatment. We wait for next about 4 to 6 weeks for the SVR to be confirmed. What do we do during that period? He should be dialyzed on the same machine, or can we take him on a buffer side or a negative side?
So I'll tell you what we are following. So what we follow is that we do twice HCV RNA to confirm SVR. So 4 to 6 weeks after the completion of the course first, then again another 4 to 6 weeks the second. Till that time he remains on the HCV positive area. Once we confirm twice, then we take him to HCV negative area, but single use still. Single use, no use. But I mean, there may be other ways of doing it. So, yes. Jyoti.
So many times we get particular patients who are on TCC and then particular organisms from a single center or let's say different center. So depending upon the organism, what can we advise the center to look for to prevent further these infections?
You mean advising another center?
I mean, we can give, of course, I mean, they follow or not is a different thing, but of course we should, I think.
I mean, Rajavika sir had said that in the morning, but it's very difficult to, tell somebody else that you are doing something wrong. It's really difficult. That's why maybe it is going to be useful to build bridges so that you need to devise a way of communication first. Okay. If they have got a particular organism coming again and again, and we also see like fungal happens outside, but how to tell them? And it may be multifactorial. Okay, so center may not be itself a fault, maybe the patient population also. So there are a lot of things that we may be able to do, but I'm sorry, but I don't have a good answer how we actually put it in practice. And I welcome all the suggestions because this is a real problem. I just showed our data. Half of the patients that we diagnose as CRBSI actually coming from outside. They getting dialyzed outside, come with a CRBSI, getting admitted with us. Now, how do I prevent that? I don't have a good answer to that, honestly.
Just to comment on that only. So most of the monas are waterborne. So if you are getting a lot of monas, whatever monas, pseudomonas or others, it is water. So you have to tell them that water is a problem. Aureus is again hand hygiene. There is no doubt. So we have also similar like buyback. We are growing same organism again and again in a particular group of patients. Then we realize it is from our bicarb. The moment we change the bicarb to buyback, that disappeared. So a similar organism coming, you have to see whatever organism, there is a problem with water or a bicarb. And ODs are always because of hygiene, there is no doubt.
So yes, the non-fermenters are often water associated, let us say. But that doesn't necessarily mean they're coming from dialysis water. There may be contamination from skin. So it's hard to tell that your water is wrong or your water is at fault. It may be just the contamination factor exists. Right?
Sir, we spoke.
Sir, it's very difficult to tell another unit that your RO system is at fault. Yeah, maybe.
Hello, sir. So, sir, we spoke about perm cats, but situations we are facing is that when we transition some patients from temp cat to a fistula, where may not be able to, maybe we may not be able to use perm cat for them. Real situation, we are facing two situations in them. One is obviously the infection rate, which is very much more higher in the temp cats, and second is the dressing, which keeps on getting out, and that sticky material may be source of infection sticking on them and everything. So what does your unit follow in terms of dressing for the temp cats, and how do you tackle or maybe ensure temp cats don't get infected, the temporary dialysis catheters?
So, no, I'll try to answer this. I'll probably seek answer from others. But the reality is that we don't have too many temporary catheters. As soon as we know that this patient is chronic and going to need long term, he is on perm cat, even while awaiting fistula maturation. So, but the temporary catheter is a problem because some patients are there in hospital or come from outside, and I would suggest follow the same precautions as a perm catheter as much as possible. But the other thing is, I have found is curved catheters for the jugular are better to maintain rather than the straight ones which stick up. So that's just a simple practical point I can make. But if you have got a curved jugulars, then they are really easy to maintain. But follow the exactly same protocol as perm cat, as far as prevention of infection is concerned. But if there are any other suggestions, I am open to hearing going.
Dr. Lobo?
Yeah, I agree with you fully, because the long straight catheters, the biggest thing is that no dressing seems to hold them. So that dressing peels away, it's pushed back with all the dust and other stuff that it has accumulated. And that's really the problem. So some time back, what we did was to make patients wear headbands to keep that, reduce the weight on the dressing. Another thing is to use a stronger adhesive dressing, but that has its own problems, Diana. Plus, pulling it off, it peels skin in sensitive patients. So perhaps the only way to get rid of catheter infection is not to use catheters, and that doesn't appear at the moment to be a problem. But like you've been saying, like you said also, we face exactly the same. Ganesh is here. His thesis is on CRBSIs, and out of the 100 patients that he has collected till now, something like 79 have come from dialyzing elsewhere, coming in with CRBSI. Candidal in endocarditis. So all these are problems. And then, as you said about anything ending with monas, well, not all. Siddesh is gone, but he showed us a case some time back in which there was a rare organism, porphyromonas. So we looked up where does this come from, and we found it comes from cat's saliva. And we found that that woman had 18 cats in her house, and they were chewing the ends of the perm cat. That was very clear.
Okay. I'll try to answer Jyoti's question on how to modify practices in other centers. If you are in good liaison with the nephrologist who is managing that center, he may not be able to pay a lot of attention to the technicians. But we, in our case, we called those technicians to our center and rotated them for about 7 days and taught them good practices, what we are following, our technicians are following. That has helped. But again, it died down because of lack of follow-up. So the same thing.
Some of that actually is sort of being taken care by the dialysis technicians, CMEs, that we sometimes, our Indian Society of Nephrology Pune branch does organize at least once a year. But then those technicians need to attend, because some of the training can happen systemically as a collective effort. And that definitely help. Yeah.
So, on that, I think advocacy is important. To be taken by professional bodies. The education of dialysis technicians. A statute should be brought by local organizations or governments where a certain minimum retraining, like you do for, say, licensing purposes or all. That might be one way of ensuring, because if they are then stopped from doing something, which is their bread and butter, then they might follow it better.
No, but as I said, this is it's always from the government perspective. If I am the health minister, then I am going to look at what? Access. Okay. So as I said, access and excellence are always going to be conflicting. So I want to make dialysis available in every district hospital. Okay. Because I just want patient to get on dialysis first, then I can try and improve the outcomes. Yes, I mean, this is always going to be a long argument between the two. So it just depends on which side of the table you are on.
Well, what you say is right, but if you're going to spend that much, then you must also ask for certain benefits out of it. Unfortunately, what has happened is that you have spent a lot of money on dialysis without even asking, are your patients surviving? Are they continuing on dialysis? And what's the quality of life you are offering? The moment you ask these questions, even the survival, then automatically you will know that you are spending money for nothing. And in which case then the checks get built in.
Yeah, I entirely agree with you, sir. But dealing with government is altogether a different ballgame. So I think we can discuss it later. Yes.
Thank you. Thank you, Mulay sir, for the talk.
Thank you so much. Thank you.
May I request Dr. Wadia to hand over token of appreciation to Dr. Mulay?